Welcome to This Explainer. Today, we're unpacking a condition that is, without a doubt, one of the most terrifying, explosive internal cascades the human body can experience. We're talking about acute pancreatitis. But as you'll see, what's equally fascinating here is how modern, evidence-based medicine has completely rewritten the playbook to outsmart it.
So, I want you to imagine the ultimate biological friendly fire. Your pancreas is this incredible organ that produces potent enzymes, and these are perfectly designed to break down the heavy proteins and fats in the food we eat. But what happens when the very enzymes meant to digest your dinner turn their destructive power on your own internal organs? Well, that is the core terror of acute pancreatitis. It is literally a process of autodigestion.
Okay, let's dive into part 1. The rogue enzyme, a microscopic misfire.
Right, so when we look at exactly why this happens, two main culprits really dominate the landscape. Biliary lithiasis, which is just the medical term for gallstones, accounts for about 70% of cases, and chronic alcohol abuse accounts for another 25%. Basically, a migrating gallstone can block the pancreatic duct, which causes high pressure and bile reflux. On the other hand, chronic alcohol abuse overloads the cells with toxic metabolites. But here's the thing, regardless of the specific trigger, the end result is always the same. It creates a profound pathological disruption of calcium signaling right inside the delicate cells of the pancreas.
Now normally, your pancreas is actually super careful. It packages these dangerous digestive enzymes in a perfectly safe, inactive form, which we call zymogens. They're designed to travel safely all the way to your intestines before they wake up and start working. But remember that calcium overload we just mentioned? It throws this entire packaging process into complete chaos. The zymogens get pushed into the exact same cellular compartments as lysosomes, and inside these highly acidic little vacuoles, an enzyme called capsaicin B prematurely snips the lock right off the zymogens. Suddenly you have active trypsin generating right inside the delicate pancreatic tissue.
And man, once that trypsin is active, it's literally like a detonator going off. It triggers this brutal cascade of other rogue enzymes. You have phospholipase A2, which begins rapidly destroying cellular membranes, causing coagulative necrosis. Then elastase kicks in, and it actually eats away at the elastic fibers of your blood vessels, which leads to severe internal bleeding. And then active lipase starts to literally turn the fat surrounding the pancreas into soap. It's a process called saponification, or enzymatic fat necrosis. It turns the entire area into a localized war zone.
Which brings us to part 2, signs of systemic chaos, when local damage goes global.
Because, as you might guess, this devastation doesn't just politely stay in the pancreas. The local inflammation quickly spirals into a really dangerous body-wide feedback loop. Activated enzymes and pro-inflammatory cytokines flood the bloodstream, and they cause massive damage to the blood vessels everywhere. This results in what doctors call third spacing, meaning huge amounts of fluid literally leak right out of the vascular system and into the body cavities. The patient experiences profound hypovolemia, or critical loss of blood volume. These rogue enzymes can even reach the lungs, destroying alveolar surfactant and causing acute respiratory distress syndrome. The sudden drop in blood flow triggers acute kidney injury, and most alarmingly of all, the intestinal barrier completely breaks down. This allows dangerous gut bacteria, like E. coli, to sneak out and invade the dying pancreatic tissue, turning a sterile necrosis into a deadly infected necrosis.
And this brilliantly illustrates just how extreme the damage is, because you can actually see the physical force of this internal bleeding from the outside. The enzymatic degradation allows bloody, hemorrhagic fluid to track along the anatomical fascia inside the body and literally stain the skin. Doctors actually look for these rare but incredibly striking visual cues. There's Cullen's sign, which shows up as dark bruising right around the belly button. Gray-Turner's sign presents as bruising out on the flanks. And then there's Fox's sign, which shows up all the way down on the upper outer thigh simply because retroperitoneal blood is tracking down the psoas muscle. These external bruises are essentially a grim window into the massive hemorrhage happening inside.
So, how do doctors handle this? Part 3, classifying the severity, scoring the damage.
Faced with this level of systemic chaos, intensive care doctors absolutely need highly accurate ways to quantify the destruction. For years, the standard has been the revised Atlanta classification, or the RAC. Now, the RAC is very strict. It largely judges severity simply based on how long organ failure lasts. Is it transient, or does it persist beyond 48 hours? But critics argue that's a bit too static. It essentially treats a stable single-organ issue the exact same way as a spiraling multi-organ collapse. Enter the determinant-based classification, or DBC. The DBC is far more nuanced.
It integrates not just the organ failure, but also clinical sepsis and the specific local status of the tissue necrosis, meaning it checks whether that dead tissue is sterile or if it has become infected.
And here is why this matters. The DBC isolates the absolute highest risk patients into a unique critical category. A patient lands in this category when they suffer from the coexistence of infected pancreatic necrosis and persistent organ failure. This specific, terrible combination carries a shocking 40 to 50% mortality rate. This right here is the ultimate high-stakes battleground for the medical counterattack.
Let's look at that counterattack in Part 4, Rethinking Fluid and Food, the Waterfall Paradigm Shift.
To fight back against this critical threat, modern medicine actually had to completely rethink its approach to basic tools, like IV fluids and food. For literal decades, international guidelines told doctors to aggressively flood acute pancreatitis patients with IV fluids. We're talking up to 500 milliliters an hour. The idea was to counteract that massive fluid leak we talked about earlier. But a landmark 2022 clinical trial called the Waterfall trial actually had to be stopped early. Why? Because of this number, 20.5%. That was the rate of dangerous fluid overload in patients given aggressive fluids, compared to just 6.3% in those given moderate fluids. Aggressive fluid resuscitation wasn't saving patients, it was putting them into cardiopulmonary overload and making everything worse.
So today, the medical counterattack is totally different. It's defined by a strict less is more philosophy. Doctors now use tailored, moderate fluid resuscitation, and they specifically favor lactated ringer solution. Even more surprisingly, the old logic of starving the patient to provide pancreatic rest has been completely thrown out the window. Now the goal is to feed the patient early, usually within 24 to 48 hours, using a nasogastric tube. And the reason for this is actually brilliant. Keeping the gut fed maintains the physical barrier of your intestines. It literally stops those dangerous gut bacteria from escaping and colonizing the dead tissue in the pancreas.
Which leads to our final chapter, Part 5, the step-up surgery, putting away the scalpel.
So, what happens when that necrosis does unfortunately become infected? Well, this builds on another incredible plot twist in medical history. Historically, if you had dead, infected tissue sitting in your abdomen, surgeons immediately rushed in to cut it out. It seemed like common sense, right? But the 2010 Panther trial and later the Tension trial proved everyone wrong. Rushing in with a scalpel for primary open surgery actually caused far more major complications and higher death rates. These trials proved conclusively that a patient minimally invasive step-up approach was wildly superior.
Think of this step-up approach like a surgical staircase. Step 1, you initiate targeted antibiotics that can actually penetrate the pancreatic tissue, like meropenem. Step 2 is where it gets incredibly counterintuitive. You wait. You actually delay any minimally invasive drainage catheters for at least 4 weeks. Now, waiting requires serious nerves of steel from the medical team, but it allows the necrotic collection to safely wall off into a mature, encapsulated mass. That makes it so much safer to eventually drain. Only if the patient continues to deteriorate do you move to Step 3, a minimally invasive debridement, usually using tiny cameras and small tools threaded right through the established drainage tract. And amazingly, about a third of patients resolve fully with just the catheter drainage, avoiding real surgery entirely.
It is a huge, profound shift in surgical philosophy. Open necrosectomy, that aggressive, immediate open surgery of the past, is now strictly reserved as a last resort salvage therapy. It's only on the table when a patient suffers refractory sepsis or their abdominal pressure is literally threatening their life, and all the minimally invasive techniques have already failed.
So we've seen how acute pancreatitis triggers one of the most violent, explosive conditions in the entire human body. Yet all the evidence clearly shows that fighting it with aggressive fluids and aggressive surgery usually just makes it worse. The true triumph of modern intensive care here actually lies in calculated restraint. It's about tailored fluids, feeding the gut early, and having the sheer patience to wait weeks before intervening surgically. It leaves us with a pretty fascinating paradox to consider. In our modern age of extreme medical technology, could the ultimate life-saving strategy simply be having the wisdom to know when to do less?